All right. Okay, so Richard, we've had some discussions. I think we filled you in a little bit on, our hope with these employer roundtable events or activities are really to start to expand the kind of the benefits, local benefits knowledge of employers around the Missoula area, hopefully expanding out broader to the rest of the state once we're pretty established with, having a strong kind of base of folks who are pretty sophisticated. Obviously, that's our group starting right now already represents people who are pretty sophisticated with benefits and health plans. But one of the things that we were talking about is, there's the opportunity that several folks, even a couple, I believe, in our group who are considering self-funding. And we all know healthcare costs are rising uncontrollably, it seems. But if we were to host, say, like a workshop, and people, the title of that workshop would be something like, self-funded versus fully insured, know your options, or something like that. How do you make the case to an employer to consider going self-funded? Like, what's the asset level that they would need? I think we've all heard that it's around 100, employees is kind of the minimum that you would want to go self-funded. But what is your recommendation regarding specifically, like, what's what the cost would be, and what are other factors that you might want to consider if you're an employer before you go self-funded?
Sure, I'll try to take a stab at that, Emily. I know, Erica, you guys are self-funded. Robert, are you guys, or Doug, either one of you self-funded at this time?
We are, yes.
We are partially self-funded. We're in a captive.
Okay, yeah. So, Emily, I'll take it at kind of layers of an onion. Okay, so if you're in the greater Philadelphia area, if you're in Los Angeles, you have you're much less likely to be self-funded than you are in a rural state. And part of the reason for that is when you have a lot of competition for your business as an employer by the commercial insurance market. There's 3, 5, 7 insurance companies, United Healthcare, Cigna, the Blues. Everybody is coming to you saying, hey, we can get you a better deal. Then you tend to have in any given year, some company wants to gain market share. And so you'll potentially, in a large market where there's lots of competition, you'll potentially have an insurance company that's willing to take a great deal of risk, which is to say, have perhaps a rate on the table, a fully insured rate that's so attractive. Why would you pass it up? And so in those markets, you tend to have less self-funding. In markets like Montana, most rural states, and even most of Texas, for instance, it's kind of a regional thing. Self-funding has taken hold. My dad started a TPA way back before ERISA. And so I grew up in the self-funding world. I have kind of a bias toward it, even though I'm running an insurance company. But to my mind, it typically makes sense long-term to be self-funded, even if you have the opportunity in a given year to have a slightly better rate than you might have being self-funded, because you're going to have somebody kind of lowball your price because they want your business. As HR directors, you guys know it's a pain in the fanny to communicate all the benefits, the networks, et cetera, to your employees. And by shopping around and being willing to move every year or 2 or 3, you can probably get a better rate being fully insured in those major markets. Possibly not in Montana, by the way. The major markets, yes, but in over the long haul, I think your employees appreciate the stability of not changing networks and administrators, because eventually your claims catch up to you if you're a large enough firm. So what is large enough? I'd say it's a confluence of 2 factors. One is, as you referenced, Emily, the number of employees. The other is financial stability. So Robert, you work for a financial institution. And so, just by its very nature, your capitalization per employee is higher than if you're in a retail organization. So there's a lot of capital there, which means you can afford to take more risk. You can afford to have, because with self-funding, you might have a bad claim year every 3 or 4 years. And you've got to be able to absorb that. Even with a stop loss, you can have some bad years. And so having financial stability, not just solvency, but stability is a factor. So, for instance, for many years, the kind of rule of thumb has been 100 employees and up. It makes sense to self-fund. I'd say if you're a financial institution, or for that matter, I'm thinking of a business in Billings, Montana that I used to do business with. And they are the front end of kind of a mining company. They have very deep pockets, and they have 60 employees. And why wouldn't they self-fund? They've got, and they're going to eventually, the claims will catch up to them because they're not below 50. If you're below 50 employees, they're near in that regulated market. This is a different discussion. But so if you have very deep pockets, it makes sense to be self-funded, even if you're a little smaller. If you have a lot of turnover in your employee population, I could suggest it makes sense to be a little bigger. And likewise, if you're more thinly capitalized, or I remember having a lengthy discussion many years ago, this goes back to the 90s, with an HR head, a VP of HR, and the CFO was there. And in the conversation, the CFO said, I don't know if we sign a non-disclosure, we're going to ask you to keep this quiet, Richard. Said, this company's for sale. And it's been for sale for a year. I don't know if it's going to happen soon. It doesn't make sense when you're in that kind of, because there's some complications with a self-funded plan when you go into merger and acquisition. So there's things that go on that are beyond just the number of employees. From an actuary standpoint, the real number is 200 employees typically. From real stability in terms of being able to predict claims, you get about 200 plus, and you can be fairly predictable, especially if you don't have a lot of turnover. If you're in an organization like a county or a city where you've got a good pension program, you're not churning through people the way a hotel operator will. And so if you have low turnover and you've got a couple of hundred employees, you can predict those claims pretty well. Between 100 and 200, what firms find is that you'll have 2 good years and 1 bad year. And so you just make sure you have some plan assets that you put in the plan that are there to protect your employees and your company. And it can make plenty of sense to be self-funded at 100 plus. To me, you have to really make the argument to go 50 plus, but at 100 plus, it typically can make good sense. I'm probably over answering your question. I hope that makes sense. And if anyone has any questions, I'd be happy to go on.
Yeah, and Doug and Erica and Robert, please feel free to jump in anytime. I do have just the questions that we had already discussed at the last roundtable, but feel free to jump in and ask, any other questions that you want to ask.
I actually have a quick question, and it kind of, Doug, it points to your folks' plan, because you have, like you say, you're part of a captive, but do you consider yourselves a partially self-funded plan?
We do. We are responsible for paying premiums up to a certain amount, and then we have stop loss insurance, and then the captive at some point pays. So it's layered.
I see. And do you see a lot of that out in the world now, Richard? Do you see a lot of that, those modified self-funded arrangements?
The whole captive concept has really taken root, and that's where, if you would have asked me 10 years ago, I would have said, "Oh, it's a flash in the pan. There's no reason to do that. We won't see this really go anywhere." And I would have been 100% wrong. There's some good reasons to have a captive, and it depends on your business ownership. But if you're privately held, for instance, it can be a way for the owners to, it has some certain tax advantages, taking some kind of smuggling money from 22 into 2024. There's some things you can do with a captive that are pretty attractive. And so I found I was wrong in that. I think the captive concept has some value, not only there, but also in some risk sharing, because the one of the real dynamics, I was going to say scary things, but that sounds fear mongering. One of the things that is most interesting and complex about being self-funded is the issue of stop loss insurance. So, if you're Washington companies in the old days, they had to kind of shrug their shoulders. Do we really need this? Again, what are they buying, because they could pretty much buy and sell most of the stop loss companies. So why would they go out and buy stop loss insurance at $100,000 or $200,000? I believe they did buy, as part of a general policy, I think they did in those days, have some sort of layer. But also in those days, you could put in your policy language to your employees until 2012, I guess it was. You could say, hey, this program is going to provide you $1 million lifetime benefits. And so it made it a little easier to arrange those self-funded layers. But obviously, you want to have a very thoughtful consultant, looking at your stop loss and where it's layered, and reading the policies and protecting you. I have found that I've kind of surprised myself in that, again, that's an area where 20 years ago is kind of the Wild West. And today, I think most of the good stop loss brokers, I'm talking about stop loss brokers, not consultants that advise you, but the big houses that the MGAs, if you will, I think they do pretty good work, and they do a good job of making sure the policy language is not horrible. It was not always the case. You had policies that had really poor protections built into them back in the 90s, and you don't see that nearly as much. But so anyhow, the captives and where you align, your stop loss, if you have a captive, and where they get their reinsurance, is just something you want to be, very thoughtful about, and try to put in there if you can. It's usually ineffective, but if you can put in 60-day notifications for renewal and make sure you get your, because the protections of your insurance department that apply to a direct policy with a, for health insurance, those regulations go away with stop loss. And so you just want to be, it's kind of like buying your liability insurance. You have to read the contract very carefully, but you need to have it. And it's no longer as frankly dangerous and filled with minefields as it used to be, in my opinion.
I have a question. So Robert brought up at our last meeting, kind of going down this kind of workshop conference route again. If we were to host something like this, the benefit of having kind of separate tracks for different, types of employees, like what would benefits and HR directors, need for, to go self-funded? But on the flip side, there are the folks they really need to convince are the CEOs and the CFOs, right? So what recommendations would you have for those, that executive team?
Hold on just one second, Emily. Yes.
Yeah.
Oh,
For your response on that RFI.
thank you.
So
Yes.
think about-
Okay, this will be over soon. Thank you.
You just muted yourself.
You went on mute there, Richard.
Oh, okay. Sorry, I had somebody leaving for the weekend that had a quick question. I apologize.
No
Emily, could
problem.
you repeat your question?
Yeah, so just looking at kind of, what is, so the folks who ultimately kind of, hold the purse strings, the CEOs, CFOs of organizations who have to make that final decision on, self-funding, what is the information that they would need, to really make an educated and wise decision around self-funding, self-insurance?
I'm kind of a dinosaur in this business, and I'm old-fashioned. I'm just going to lay it out there, and I think it is very important for an employer who's going to be going self-funded or considering it to connect with an ERISA attorney, and they're hard to find in this part of the world. We're not in downtown, Philadelphia or something, or Chicago, and But there's ERISA attorneys around. There's some good ones in Montana. Elizabeth Ned, I shouldn't mention it, but Elizabeth Nedrow out of Holland and Hart, and they're never cheap. And but I think having someone look over your plan documents, look at how advise. So part of the reason I feel this so strongly is because I've just seen companies, and you guys are probably all taking care of your knitting here. So I hope I'm not offending anybody at all, but I think, obviously offending you by patronizing you by speaking down to you. Cause I feel like I just throw it out there and, but you're taking employee money and you're holding employee money in trust and you're a fiduciary for those employees. And what I see constantly, I've seen it my whole career, is employers don't always go into this with all eyes open, understanding, this is a real opportunity to, stabilize a significant portion of my expenses, but it's also fraught with, challenges down the road if I'm not thoughtful about this, not careful about it. So you've got to segregate the account. You've got to, be very careful about making sure the employee's interests are protected. And I think that, I see very few ERISA trusts set up by employers nowadays. And a lot of general attorneys, in-house counsel will, they're not always very well advised. That's why I'd say first start with an ERISA attorney. Secondly, find a fee-based consultant. I've got a dog in that fight because I spent a lot of years as a fee-based consultant. I just think there's a difference if you have a commissioned insurance agent, and these are friends of mine, and I don't mean to be critical, but if you have a commissioned insurance agent in the mix, I think you've got a bias then. And I just think it's important to have a fee-based consultant to help bring together, unless you're a big enough organization, you can do this yourself, to bring together really good proposals from the TPAs and the stop loss carriers to, find a good MGA for the stop loss to help navigate that for you. So a good fee-based consultant, which is not the same thing as the ERISA attorney at $725 an hour. You don't want to use them for that, but and you don't need to use a lot of hours, but you need to get it set up the right way, get the plan documents in place appropriately, because ultimately you're liable for these employees. And so, and I also am a believer that these plans should be funded. I don't think they ought to be, even if it's entirely employer paid. I think it's very dangerous and foolhardy to have these on a pay-as-you-go basis. I think there ought to be some funds that are segregated, take at least 3 months, of claims, estimated claims, have them in an account. If the lights go out in the company, those funds are there to pay out those claims for injured employees and their families, and make sure that you don't end up in a situation, because that's its own liability, and you've got a fiduciary responsibility to the employee. So those are, a couple of things: the ERISA attorney, fee-based consultant, and expect and demand a pro forma on this. If someone's not self-funded already, get a pro forma that takes it down the road 3 years. I don't think you have to have an actuary, but there are some good actuaries. They're not that expensive compared to an ERISA attorney. And to have an attestation, even though it's not required by anybody, as a thoughtful employer, to have someone who is really capable and proven capable. Now that's to get it started. I don't think you need to have an actuary do an attestation every year, unless, it might be smart, Erica, for you guys being in a public plan, but private employers don't need to go to the expense of an actuary typically on an ongoing basis. I just mean getting one started. Those are the kind of things I would say to a CFO and a CEO is there's some real savings here. Probably not going to get all those savings in the first year, because you're going to spend 30 grand on consultants and just to get going. And then you avoid a lot of problems years later, which I've seen those problems take root.
Great. Does anybody have any questions just yet? Good. This is all really interesting. So one of the other things that we talked about are some, just trends that you're seeing, among both self-insured and fully funded. Can you talk a little bit about what you're seeing? Really, what are some of the reasons that you're seeing folks decide to go, fully insured, fully self-funded, or remain fully insured?
Yes. So, increasingly, so again, I'm running an insurance company. We do health insurance even for employers, but typically these are small employers, 20, 50 employees. We have some large employers, but not jumbo. And in our business is really individual. It's 80% of our members are, getting a marketplace subsidy through the Affordable Care Act marketplace, healthcare.gov. And so that's where most of our business is. But why am I talking about my company? Because what you find is insurance companies, they tend to build the chassis of the vehicle around fully insured business, which has requirements that self-funded plans do not have. And they tend to not want to, I'm kind of and by the way, we have a TPA. We don't administer our own claims. We have the University of Utah Health Plan as our TPA. So that's why, again, we're not at all in the self-funded world. But what I would tell you is that if you're doing business with an insurance company, I'll pick on Blue Cross because they're here. Pacific Source will do self-funded, but they sometimes will bring to the table all of the features that are required on the fully insured side that are not required on the self-funded side. And it can be limiting to you in ways. So you talk about what are the trends? I'm kind of getting there the long way, Emily. Some of the trends would be, to my mind, we're seeing a little bit of a return to managed care, not as much in this neck of the woods, but we're seeing a bit of a return to that. I'd say, thoughtful plans are looking to, try to bring a separation at times between the primary care element and the rest of the medical system. So, a lot of the movement, a lot of the there's Liesl. Hello, Liesl. How are you? Good to see you. But so before, I think some of you had not joined yet, but Liesl is on my board. So now I'm gonna stop using all the expletives. I'm gonna start behaving. So Liesl, by the way, is featured in this month's edition or this quarter's edition of Montana Quarterly. And so I think you want to pick that up at your newsstand now. It's a nice picture of you, Liesl.
Well, thanks. It's just a picture, everyone. It's not an actual feature article, so it won't be that bad. And sorry, Emily, that I was late. Hopefully you remembered my email.
Yeah. No, we're just glad to have you. I'm now going to look for the Montana Quarterly.
So I was just getting around, some of the trends I'd say are you want to try to get ahead of the curve in terms of controlling healthcare costs. Erica, you guys have done this for years, I think, and have been a kind of a thought leader in Western Montana at the county. You do some cool stuff there that nobody else is doing. And but I think, to my mind, what you see nationally is there is a concern that when you have the people that own the magnets, anybody know what I mean by magnet? MRIs, PET scans. So the people that own these heavy diagnostic equipment, and that own the facilities, when they control the entrance to that with their own primary care, you can see costs driving a little faster. And it's not like any of the folks on this call are a size where you have 5,000 employees in a factory and you can kind of bring in your own clinic, but doing what you can creatively, and Lisa, you guys have done a little bit about on this line too, to creatively try to detach some of your employees from the machine. And by the machine, I mean the healthcare industrial complex. So the healthcare industrial complex is coming to a store near you. So the hospitals 20 years ago, how many physicians in the state of Montana, how many physicians in the year 2000 were employed by hospitals? except for emergency room doctors and the chief of staff, that have one doctor, chief of staff, that are the emergency room doctors. In the state of Montana, there were 16 doctors employed by hospitals in the year 2000, other than those two exceptions. Today, it's probably 70% of physicians are employed by hospitals because there's so much money to be made in the heavy diagnostics and in the specialty care and the invasive care. They take those dollars and subsidize the primary care doctors and mid-levels. And so trying to break that unholy alliance is something that's a bit of a trend. And it's not something that any one of you could do on your own, but maybe again, kind of as a coalition, to try to break the lock on that, I think could be helpful. And I've got to be careful here too, because we have some great people working for hospitals in Montana. I just want to say that. I mean, friends of mine, and these are not, but it's a system. It's a system, and it's very hungry financially right now because some of them kind of spanking with COVID, and so they're trying to make up for lost ground, and so that would be the one thing, is trying to separate that out with primary care. Separate. I think it was United Healthcare just made a huge purchase in Seattle. Might have been $1 billion for a big clinic that expands over several geographic regions, but mainly in the Seattle area, buying up physician clinics, trying to create this separation. And I used to work for United Healthcare, and they're, again, some nice people there, but they're not doing that so that they can necessarily benefit the employer. They're doing it because they see the hospitals making this margin. That's my cynical take on it. So I think healthcare is not in a good place in our country. The costs are going to be going up the next couple of years, and doing what you can to build a fence around your employees so that they can, you can give them great access to primary care without them, then always being referred off to a specialist when really what they need is to come back next week or get some physical therapy before they get into the hands of the surgeon. So we see a lot of a high incidence in this region of orthopedic surgeries of certain types, lower back and others that compared to other regions of the country. And so how do you pull away from that? It's hard, but I think those are the kind of directions we need to be thinking about.
I was just going to mention, Emily, I think some of those topics are things that we should put on our list too, for our group to discuss. I mean, I put those in that bucket of creating arrangements direct to provider arrangements that would help. And again, not to focus only on self-funded, but self-funded has the flexibility to do a lot of those things. So those provider directed arrangements can help you attack some of those costs, like you're mentioning.
Right.
And I always struggle, Richard, with if I'm a smaller employer just in the fully insured world, there's really not much you can do in terms of those types of arrangements, other than just work as closely as you can with your insurer, right?
Yes, and yeah, when you're fully insured, you're the insurance company's hands are tied, and so your hands are kind of tied as well with them. They're limited, and even when they don't have to be tied, it's hard to go outside of the system in a fully insured carrier to, they're going to want to do it their way. It's just hard not to, and they're building the engine for the fully insured, which is heavily regulated, and so sometimes it's better to be with an independent administrative firm as opposed to a carrier.
Anyway, go ahead, Emily. I was taking us off track too.
I saw Lisa. I did want to mention one thing. Talk about trends and stuff. I did want to spit this out, and it's Lisa mentioned, I think in the chat, if I saw that correctly, I was on a radio program earlier this week. There's an opportunity. It's if you haven't done anything about it at this point, probably not for right now if you're renewing on January 1st. But the feds, of course, have now extended advanced premium tax credits to the family members of your employees. And so strategically, if you could find that some of your employees, if you're charging, I'm just going to pull a number out of the hair, out of the area. You're charging $200 to add a spouse. You're paying for almost the entire employee premium or contribution, but you're charging for the spouse $200. It could well be that that spouse can go in the marketplace and have more affordable coverage, especially until 2025, because right now we still have those ARPA tax credits. So the subsidy on the marketplace or the through healthcare.gov is higher than it had been a couple of years ago. It increased with COVID, and they extended that a couple of years, and they've now taken away. There was an estoppment that you could not get the advanced premium tax credits until now if you had the opportunity to get family coverage through a spouse. So that's gone away. It's called the family glitch. So if you want to learn more about it, just Google family glitch. But it's an opportunity for the employer because, typically, especially for the larger employers like those represented on the phone, a smaller employer often will pay nothing, zero, toward the family. They just pay for the employee. That's very common in Montana. So for those folks, this is a godsend. But for you folks, there's also an opportunity because you are paying typically a significant chunk, and that's something you need to, as you strategize. And of course, the feds came out with this, at the end of October, so it's too late to mess with it this year for you guys if you're January 1. But for the future, you want to strategize around how do you make that work for your employer and for your employees. You don't want people to end up uninsured, and frankly, trying to encourage them to leave your health benefit plan can be counterproductive because that can be very sticky because the spouse is the one that may often say, don't quit that job. I know you hate it, but you better stay there because we're getting our benefits through it. So, you want to be careful before you take them off. But if you're in a situation where you have low participation because you can't afford to pay the whole meal deal, and so you have people that are uninsured, well, there's an opportunity to be of help to them and say, hey, make sure you get coverage. So it all depends what your strategy is. If you're already funding it at a very high level, that may be just fine. But this family glitch thing, I think, is something you've just got to do the math on and see how it would work with your employee population. Okay, I'm done now, Emily. Sorry.
I think, no, that just, I'm really interested in personally hearing more about that, just because my husband's spousal benefits are really outrageous through his job, but just the premium that we pay for that. But I was gonna ask, we're talking about the trends again. I'm just curious, and you guys, anybody else jump in, but you mentioned something in your email here about reference-based pricing generally being done poorly. There's a big movement at the national level, and my colleagues here know I've talked about this ad nauseum. The SAGE transparency tool that the National Alliance and NASHB and Employers Forum of Indiana and RAND and all those groups have put together to start really, leveraging this transparency movement, right, to try to control costs. Do you see that being something that's happening yet? Probably not so much in Montana, but have you seen trends around, really focusing on employers kind of taking the reins and saying, hey, we know you're not actually, to a hospital system, this is not actually costing what you're saying it's costing, or, whatever their argument is, because I know that that's something that, there has been reference-based pricing here in Montana. What are your thoughts on that whole system?
Yeah, so, it's one of those tools when I mentioned earlier about, if you're with a fully insured administrator, they're not in a good situation typically to offer reference-based pricing, and nor is it typically something everybody wants to jump into. But it's a tool, and a great example of reference-based pricing. You want to be very careful about out of area. So you have employees that say, gosh, I saw this commercial, Florida Cancer Centers. I've got to go there. And it may be 8 times the price of Medicare, maybe 800% of Medicare pricing DRGs, but that's where I want to go. And oh, by the way, they're in this network because you've hobbled together this kind of flimsy national network that you really don't know who's in and who's out. And you find out the hard way. So I think especially for out of area, it's something that, you had to be thoughtful about maybe using at times, a reference based, but in it, like in the city of Missoula, I don't see that necessarily being the solution, just because it does create a lot of noise from the employees. It's hard to administer properly. I'm glad it's out there because otherwise, it's a tool, but I just don't think that, but getting back to the transparency, I think that will have an effect. We saw in our market, we're in Idaho, Montana, and Wyoming, the largest hospital is St. Luke's down in Boise, they're probably twice as big as the next biggest hospital in our catchment area. And they, January 1st of 22, so almost a year ago, they came out and said, everybody pays the same price. All the commercial payers. Now, Medicare, Medicaid, there's other things, but for commercial payers, it's one price. They haven't actually gone all the way and said, if you walk in here and you're uninsured, that's your price. Now that to me is where it needs to be. You go in the grocery store and everybody pays. I wish I knew our kids are gone. We don't buy milk anymore, but a gallon of milk, let's say it's $4. I don't know, but it ought to be $4 for everybody. It shouldn't be $6 because you're uninsured, $3 because it just doesn't make any sense to me. But anyhow, so I hope to see a situation where this leads to a pricing mechanism that's more appropriate. And what I hope it doesn't happen, and this did not happen in Boise, did not happen. I hope it doesn't. So I hope it isn't like, well, we're going to take it to the highest price now, and that's going to be your price level. I hope it's in Boise. They actually came down a little bit and said, here it is, everybody. And I think the reason they came down a little bit is because they had a special deal with one of the payers, and they kind of ended there. So I foresee good things happening with it. And there's you guys are kind of building up, I think, bit of a discussion coalition there, and that's so important. I mean, Don and I have a lot of history here on this, and it's got to be the community. It's got to be the community gathering together, sitting down, major employers, drag Washington companies to the table, bring some bigs, sit down, have the hospital representatives in the room together, not apart, and say, hey, we want to talk about healthcare for our people. We want great healthcare. We want it to be covered. Transparency. How can we move this forward? And that's not happening, but it needs to happen. So I'm sorry, I'm going on the soapbox here. I'll shut up for a minute. You guys talk.
The box is great. I mean, I don't. That's the end of my questions that I had formally developed. But does anybody else want to ask Richard anything while we have him here?
I'll jump in really quick again. I can't help myself. I think that is the kernel of what we're trying to do too. What Emily and I are trying to do with the coalition is create a platform where things like this can happen, because the coalition does provide like I say, a platform. If we get enough employers, if we get enough momentum built up around it, those types of conversations can be held. And we can be that employer block that has that discussion and can then work with local providers for different mechanisms that they can help our local employers with those types of things. Even if it's just pure and simple transparency, just so we can see what pricing is. Because you can imagine that even in our locale, the price differences for one group is probably different for a different group. Those are the types of things that I think that the platform that we're talking about can help with. And I think it's a great segue that leaves us with a lot of, we need to process too, Richard. Your comments leave us with, at least myself, with ideas of how can we make that easier for people like Robert and Erica and other groups that where we can actually have a forum that can draw in fully insured, because it is their community also, and trying to pull that together along with self-funded efforts in the same area.
That's great.
I have a quick question, Richard, while we still have you. And this is just, this is a little bit off topic. So forgive me, but what are you hearing around Helena as far as any potential legislation that's coming up at the state level that should be on our radar as, you know, an organization that's representing self-funded employers, and also, you know, what could affect, I mean, I realize it's the state, and so it's not really going to have much of an impact, but I'm thinking about like the vaccine mandate, or the vaccine ban from the last legislative session. I've heard from some folks, you know, and then the mask, you know, removing the mask, the ability for, you know, local health departments to have masks. I mean, I heard from some small business owners during the last legislative session that was a concern for them, because if, you know, if they have, you know, if people aren't required to wear a mask, or, you know, they're not allowed to, you know, tell their employees they need to be vaccinated, if they lose, you know, one person for 2 weeks because they're sick with COVID, and that's, you know, they have 10 employees, that's 10% of their workforce, right? So are you hearing anything, you know, that we might want to keep on our radar, is, you know, because we do have some advocacy efforts that we are undertaking as well?
No, I mean, from the highest level, Emily, what I have heard just this week, we got a little bit of inside information that the governor is leaning hard on the legislative leadership to deal with the budget first, and then get to what in Helena they call it the cats and dogs. That means all the other bills, you know, the bills that are going to, you know, whatever, outlaw capital punishment, and they're going to, you know, regulate banking in some fashion or whatever, all that stuff later. Budget first and taxes first, kind of get that done, kind of get the business of government out of the way in the first half of the session, which I think is a really good thing. And because it also requires them to kind of spend some time on some of these other bills. What I would say just in general is I think the employer, when it comes to healthcare, the legislature sees healthcare through the lens of the hospitals first. Secondly, insurance companies, because we have lobbyists. You know, Blue Cross has lobbyists. We have part-time lobbyists. So when they think of healthcare, well, first they're thinking of Medicaid, because that's a big part of the budget. But then you get in below that, and the hospitals are controlling a lot of the conversation. You would be surprised how many legislators sit on the board of their local hospital. And that's not a bad thing necessarily, but there needs to be a voice in healthcare, about healthcare, from the folks on this call, from employers. Employers are footing a big part of the bill. What happened, and Don got a first row seat at this several years ago, is the state of Montana used to lock arms with the private employers to look at this. The state peeled off and said, we're going to do our own thing. And that's too bad, but that's the way it is right now. And I think that old system kind of allowed the view of employers to kind of reach Helena. So I'm not very optimistic about where I hear things right now. Employers need to be heard. And because you folks are representing also your employees. It's not just the employers, but the employees who are contributing to your plans. And nobody wants to talk about the cost of healthcare. They get to Helena and they hear about, oh my gosh, our hospital is going to close, you know, and they hear that over and over again because you're not paying us enough money. And, you know, those voices need to be heard also, but your voices need to be heard. And right now, to specifically answer your question, I'm racking my brain trying to think of any employer related or health truly healthcare reform oriented discussions going on. And I mean, I've tried to initiate some of those very quietly, but we're in a weird spot to do it because we have to do business with all these folks. And like I said, some of them are friends. They really are. They're good people, but it's an awkward spot for us because we try not to be at loggerheads too much because we're trying to get discounts from them, but we're not doing so good. None of us are. You know, the insurance companies theoretically are representing you employers, and we're paying too much, and we're all limited in what we can do. Banding together, the payers, the employers, and not trying to harm healthcare, just have a good, honest discussion is a great place for things to start. So if any of you know legislators have connections to them, make sure they hear from you on this issue, not just because what's going to happen, Robert, is your leadership is going to talk to your legislators about credit unions. That's the business you're in. And Mako, Erica, Mako has its own fish to fry. So healthcare is a big part of what all of you do, but it's always second tier to the industry you're in. And somehow we need to coalesce those healthcare voices within industry, within employers, and get those focused. So that's kind of my soapbox.
Well, that resonates with me. Thanks, Richard.
Yeah, thank you. Well, does anybody have any other questions, comments, thoughts? We're coming up on 3 in about 5 minutes.
Yeah.
I apologize, I was late, but did you touch on pharmaceutical at all, Richard, in the discussion?
Not really, John. What was your question earlier about I don't think that not in general, Liesl, but go ahead, Don. You may.
We did ask one question right relative to compliance on pharmacy, but really, I think that's Liesl, that's a topic that we could talk for 2 hours on. Also, it's just, it's such a large and growing part of your overall costs that it demands attention also. But I do think we need to tee that one up and have it, we can probably find a speaker to speak to that too. Maybe you want to come along and listen, Richard. That I know that that's another big part of what you're trying to deal with too.
Yeah, I couldn't speak on pharmacy, but I can listen to it all day long. It's a big deal. And there's some big, heavy hitting drugs coming on the pike right now that could really rock all of our worlds in the next year or two.
Right. I just read about one. What was it? 12 million a year. The most recent one was like it was an absolutely incredible number.
I think it was lower than that, Don. I think it was 3.5 million. And I was going to say it's like a series of several shots for hemophilia.
Exactly. That was
it. Is a certain type of hemophilia. And like all the news on drugs, it's really good news. If you're that hemophiliac, they have a cure for you that they've never had before. Where they come up with the 3.5 million or who's going to pay for it, I don't know. But there's some cool stuff happening in pharmaceuticals. It's just, unconscionable, the pricing.
That's a great question, Lisa. We'll have to tee that up. We'll have more discussions about that. I know those are things that I'm dealing with every day here at work. So.
Well, awesome. Richard, this has been really informative, and I really appreciate you taking the time today to speak to us and share your wisdom and your knowledge. And Doug and Robert and Erica and Liesl, thanks so much for joining our meeting again. And I think I'll probably send out a calendar scheduler for our next one, and we can start thinking about topics. Don, did you have any closing comments?
No, just to say thanks, Richard. That is really it's good to hear, your sincere thoughts and ideas on this. We really do appreciate it.
Very happy to be part of the conversation. Do you guys want? I can jump off if you all have more on your agenda for today. I don't know what.
I think we've. Go ahead.
Okay. Well, thanks everybody.
Thanks. Bye-bye.
Bye, everyone. Happy holidays. Thanks,
Yeah.
Richard.
Thank
Happy
you.
holidays. Good seeing you, Robert.
Good
Bye-bye.
weekend.
Bye, Erica.